All right. Good afternoon. Good morning to some of you that are coming to us from the West Coast and maybe Mountain Standard Time. It's 11 o'clock our time, 1 o'clock your time, those of you that are on the East Coast. So my name is Rocky. I welcome you back to our fifth and final module presentation on the topic that is very important as we move through this pandemic and into hopefully some recovery operations. And the topic today is Latinos and Suicide, a clinician's guide to suicide prevention and treatment. Again, all of the content herein, with the exception of certain slides that I'll mention as we get to those slides, was the content is the work of Dr. Luis Zayas, and we're very happy of obviously to have him as an expert as part of our team here at the National Hispanic and Latino Mental Health and Technology Transfer Center. So I'm going to go ahead and I want to make sure that we, give you guys an opportunity to ask questions and really make sure that you have the tools that you feel you need, moving forward as we hopefully get folks to more of a prepared, prepared kind of as best as you can. Intervention, treatment, whatever you kind of role you play within your setting. We hope that you, really think about some of the skills that we're bringing to you, and then as well as some of the tools. I also want to mention today is our last day together for this series. We are very hopeful in the very near future. I think we're going to launch it in May, is my understanding. But this training will be a training of trainers that we do hopefully across the country, and we're hopeful that some of you may reach out and want to be a trainer of trainers, which would make you a master trainer to then go out and hopefully create a ripple effect of prevention in our communities, and obviously intervening in treatment as well. So as a slide that we always reference, our network is committed to affirming respectful and recovery-oriented language that includes all of these pillars. Strength-based and hopeful, it's inclusive, and definitely inclusive of diverse cultures, genders, and perspectives. We feel that we come from a healing-centered and trauma response approach. And again, we want to make sure we don't replicate and understand that language is extremely important in what we teach and in how we reflect our the audience and the population that we speak about, which is again the Latinx, Latino populations. So with that said, I want to move forward respectfully, and hopefully with the material you see today, it's understandable and it's information that you feel is applicable to your neck of the woods in the agency, school, or community you serve. As a disclaimer, just as a notice to all of you, all of the information we share, which is awesome, I think, is funded by SAMHSA. We do ask that if you reproduce or want to copy, that you seek permission and at least let us know that you're using the material so that we can support you. We can provide maybe even some training for you before you present, and or provide some resources to you. That we always record our presentations and they are posted to our website as an important link for you all to be able to reference that moving forward. I do not have any conflicts of interest to disclose at this time. So we will again be very honored to remind everybody of Hispanic Heritage Month, which started, I believe, 2 weeks ago, and goes up until about mid-October. So we're always wanting to celebrate school mental health personnel, as they're a critical link to our families and children and communities, but also to those of you that are down, working in areas of mental health, public health, and also direct medical care, that you've never seen a break in the pandemic in the work. So we thank you and we honor you through this Hispanic Heritage Month as well. Just as a reminder, like I said, this is the fifth and final module. These will be the core modules that we do the training of trainers on, with the inclusion, I'm hopeful, whether that's included as part of the module 4 piece, or it may be an additional module, but that will take a look at self-care strategies, and we kind of highlight them a little bit today, but I really want to preface that as we move forward. So today we're looking at specifically when suicide happens in schools. What we also want to provide to you all is a summary of the previous work that we covered in the introductory modules. So just as a way of kind of tying this this series together and really kind of putting a bow on it, if you will, making sure that we highlight some of the cultural elements that are very important to consider. We also highlight some of the risk and protective factors, but more we start to look at how we can encourage and help whatever role we see within schools. Sometimes some of you are coming from a parent role, sometimes some of you are direct service, some of you are staff, maybe some of you are teachers, social workers, counselors in school settings are extremely important. And we want to give you guys some opportunities to really reflect on where you are as a school and an entity or system that provides a direct link to mental health services. And then third, discuss a case that illustrates concept related to Latino youth suicide. So we'll give you a short case here at the end. It's a little difficult given this platform, but we'll do our best to just kind of frame it for you a little bit and have you think through some of that case that we will review here at the end. I did include some additional slides that we use from our school-based mental health curriculum. So those of you that feel like school-based mental health is an area that you need further support in, maybe you need ideas on how to create a mental health task force within your school or system, though that's another training that we offer that can supplement this training as well, and vice versa. So risk and protective factors for suicidal thoughts and behaviors in youth. We always want to remember intrapersonal factors, right? The relationships, the interactions between communities and schools and peers, especially for Latino youth. Peers are a huge population that, as many of you know, peers are influenced by. Sometimes they find support in those groups. Sometimes they find maybe bullying in those groups. So we have to very much be aware of the intrapersonal factors as it relates to suicide youth, especially with everything that's going on with social media, right? And all of those areas that sometimes for parents even, and school personnel especially, can be hard to monitor all the time, without maybe you feeling like you're breaching someone's privacy or getting into areas of their private life outside of your school or community-based organization, and you may just feel a little uncomfortable with that. So we'll talk briefly about that, but I think that's maybe one other component we need to consider when we're looking at this training of trainers is what's the influence of social media on suicide in our communities and schools especially. So some family factors that we want you to consider in summary, right? Is there a history of suicide? Are there suicidal behaviors that have been reported? I think, again, being able to really look at the genogram, echo maps work really well. I think a genogram is a little bit more specific to where you kind of look at the generational levels within a family structure. And I think that will also give you some signs, symptoms, behaviors, trends in that family, whether there's substance use disorder history or misuse, maybe even just use. And there also may be mental health, depression, anxiety, suicidal behaviors in the history as well that you really want to pay attention to. We know in Latino families that oral history becomes sometimes a entity within the cultural value system that can also perpetuate violence, can perpetuate trauma, and in the case that we're talking about here, more specifically. History of psychiatric disorders, like I mentioned, you sometimes, I think in Latino families, this is especially important because sometimes suicide becomes kind of this cloak of shame or guilt in some cases. And sometimes families don't want to relive that or share that with you as the provider. But if we're able to build a relationship based on some of the cultural factors we've talked about and we're going to briefly review here today, you'll be able to develop a relationship to hopefully that if there is a suicide in the past, in the family's history, that they're able to openly discuss that. If not, they may keep that in secret and kind of keep that away from you. And it may hinder your creating a good formulation of what the problem is and how to address that in a treatment plan. Early maternal age, so again, young people young women obviously giving birth at a very young age, which sometimes is an aspect within the data that we see amongst the Latino population. But again, we can't just kind of lump all Latinos into that. I think it definitely occurs within certain populations that are even more at risk when we talk about risk factors, and that those are the things that we really want to look at when we look at that specific variable. Poverty also, again, those two comorbid with each other obviously are needing to be considered. And then of course intimate partner violence. When we look at concepts of machismo in some families, machismo can sometimes take on a very toxic masculine kind of behaviors, where we see intimidation, control, and power and control kind of behaviors. We also maybe see violence, domestic violence, abuse in its many forms, sexual, verbal, psychological, and we have to really be paying attention to that as we consider relationships that our young people and young adults and even adults obviously are involved in those families that may be obviously married and so forth. I just want to remind folks again, if you have questions, I want to make sure, and I see a question here that I'll answer in just a second, but please add your questions to the question section. If there's things that I miss, I'm hopeful that we can have our moderator also consider that. And I also forgot to mention that out in Puerto Rico, which we're coming to you from the Universidad Centro de Caribe School of Medicine, where the center is housed. I'm coming to you from Albuquerque, New Mexico. So there's been some power outages in Puerto Rico. If that happens, we're hopeful that based on the fact that I'm also an organizer of this module and presentation, that we don't have any disruption. But if we do, I just want to reiterate my email address so that those of you that want to reach out to get a copy of this presentation, or you have further interest in getting trained or other support, technical assistance, you can reach out to me as well. And that is Dr. J. Rocky, so DRJ ROCKY @gmail.com. All one word, Dr. J. Rocky @gmail.com, DRJ ROCKY. Alrighty, so let's go to our next slide here. Some risk and protective factors, again, continuing interpersonal factors, family factors, and then we kind of look at these interpersonal. So again, understanding the intra and interpersonal differences, right? Interpersonal factors may be those that are kind of more connected to group interaction and interaction that people have with systems in their environment, as well as obviously adults and other people in general. But perceived burdensomeness, thwarted belongingness, bullying, peer victimization, we also see. And I wanted to just reiterate that this work is primarily referenced through Cha and others in 2018, but also this was presented to this group, or not this group, I'm sorry, by the center from Dr. Lilian Polanco as well, who has done a tremendous amount of research in this area. Community factors now we add to this kind of list. If you can kind of get the sense, we're adding interpersonal, family, and then intrapersonal, I'm sorry, family, and then interpersonal factors. Community factors now, exposure to community violence. So let's take a moment to look at that. Exposure to community violence, what does that mean? What does that mean to us in our community? Is that from within the family? Was that violence that's coming from within the family? Or again, when we're looking at it from a community factor, is that through the lens of maybe gang violence happening in that community? Maybe it's through communities that have a large population of coyotes and immigrants that are being human trafficked into the United States and other more kind of violent experience. Oops, give me 1 second here. I'm sorry, folks. We for some reason my presentation got turned off there. All right. Okay, I hope you all can see this. Yep, it should be. Oh, it kicked me out again.
Yes, we can see it now, Rocky.
You can see the presentation. That's weird because I can't see it on my side.
I can see your your screen, but not the presentation. We weren't
Gotcha.
able before, sorry.
Oh, that's okay. Let me see if I can bring that back up for us. Okay, there we go, I hope.
Yes, thank you.
Okay, sorry about that, folks. Alrighty, so again, neighborhood poverty obviously as a contributing factor, but let me take a step back. Sorry for that interruption, kind of threw me off a little bit there. But exposure to community violence, I think we also have to consider adverse childhood experiences through the immigration journey. We also have to consider threats of violence, again, through racism and discrimination that may be perpetuated by systems, i.e. schools, community agencies, etc. And we're going to give you guys some ideas on how to start to kind of look at that a little bit more closely as we get down through these slides. Some protective factors to think about. We talked about this last week, but it's, social connectedness and even, again, familial connectedness, right? Of you also as being a person that is connecting with the family and starting to be a part of that kind of inner connected circle of the family as well is an important aspect of really having some positive effects and outcomes with the Latinx populations. Obviously, in any human experience, right, when we talk about some of Maslow's hierarchy of needs, the feelings of hope, reasons for living, those are all important factors that schools have a tremendous amount of impact on. And obviously, as you as service providers, those of you that have direct client contact, you obviously, I'm preaching to the choir when I say that. Feelings of hope. I've mentioned this, I believe, before, but at times we have to lend our students, our families, a vision of hope or try to create that with their help in the absence of hope that is currently with them, meaning that sometimes we have to try to help them paint that picture of what they want to see on the other side of maybe getting through the suicidal behaviors of their loved one, maybe getting through a suicide attempt, maybe even getting through a suicide that was carried out, by someone, by a loved one. We have to really be able to reinstill hope for those individuals. And that again is specifically us talking about, survivors of suicide. Social support and intervention. If there's a need for clinical intervention, then obviously we move to that and we make sure we get the appropriate provider that is culturally sensitive and aware and appropriate to make sure that these interventions are meaningful and that they create a difference. So as we've talked about as well, there definitely becomes some generational gaps that we see, especially around acculturation and as it relates to suicide-related risks, meaning that, when we see individuals that are immigrating to this country, and we see that maybe young people within that adolescents or young adults within that family system have also immigrated, yet there are parents and maybe grandparents or older providers, caretakers, in the sense of an adult. They may be, those adults and grandparents and parents may be acculturating at a much slower rate than the adolescents, given social media, given smartphones, given school systems, given their access to many different peers experiences as well as they're going into school in those sort of settings. So we want to make sure that we really identify those cultural gaps, especially when we're working with families. And if you have that ability, to connect families to some of this work and interventions, we think it's extremely important to think about that. And these are just kind of a summary, later generation, both youth and parents born in US at greater risk than early generation youth, meaning that if someone grew up in the United States, they're more likely to kind of have less acculturation issues than if someone immigrated to this country later in their developmental stages. Migration at an earlier age associated with elevated risk under age 12, given that we see adverse childhood experiences along that immigration journey many times, right? Sometimes immigration journeys can last months. And sometimes those immigration attempts, whether they are legal or illegal, may be thwarted, may be not approved, and those individuals sometimes take many years. And if you can imagine, sometimes immigration, following it the legal way that, we all hope that folks, take that legal route. We also understand the desperateness when people are pushed away and their legal status as a legal immigrant into this country, seeking asylum or otherwise, sometimes becomes a very long, drawn out process. We're talking, 10, 15 years in some cases. So we have to understand that stress of the immigration experience is real. We also see longer residency in the USA, unfortunately, has implications for depression and anxiety. And in many cases, I think there's a really, really good resource in the Power of an Illusion. And it looks at race very specifically. Race, the Power of an Illusion, I'm sorry, is the name of the title. And it's 3 different video modules that really provides a tremendous amount of evidence to show that immigrants that come to the United States, unfortunately, maybe they have freedoms and other benefits that they didn't have in their home country, but medically and health-wise, they become sicker. They become more dependent on systems and even create not only mental health disorders, but medical conditions that they weren't seeing in their family history, again, in their home country, like I mentioned. Greater proficiency in English is interesting because we see that may be linked to suicide risk as well, whether it's because they are more attuned to some of the discourse, discrimination, language that is used in this country about immigrants, may be one of those factors as well. So before I come on to this next area, which we start to look at more specific risk factors, I just want to add, there's a couple of questions here. So the first question is, how can I get modules 1 through 3? I didn't realize I could download them. Yeah, those are probably posted. If not, they will be shortly at the website, and the website link will be shown here at the end of the presentation. And then someone not sure if there are slides I should be able to view. Other than the slides that we're showing you right now, you can try to download that presentation, or if you go into the attachment section here, I believe they included the handout there as well. So getting back to this specific slide, looking at specific cultural factors. So racial or ethnic discrimination, right? I just mentioned that, and this is kind of in summary to the things I just mentioned. Minority stress, acculturative stress, and acculturation gap stress, right? So all of those factors can contribute to suicidal thoughts and behavior and youth, and if not addressed or intervened or prevented in adolescence and youth, obviously we then see these issues presenting themselves with young adults and adults, right? So the earlier that we can intervene and hopefully prevent, we then get to a point where we can hopefully see better outcomes, down the road. So we always have to consider cultural specific risk factors and cultural specific protective factors. A couple of other risk factors that we want to mention are, low access to mental health services. So not only if you're looking at your community or the population you serve, Latinos in general have a low access to mental health services because of the stigma, because of belief systems. But if you're also, as an agency or school, not recruiting or doing targeted recruiting of these communities, maybe that only speak Spanish, or maybe only speak a certain type of Spanish that is not translatable given the region that you're kind of referencing in terms of Spanish speaking languages, we have to be aware of those. And that, again, is more specific to when you have local experts in your communities, and that may be you all. So we can look to you all to really know what those intricacies are within those communities. Not only are Latino populations less likely to seek help, but we also see that when they do seek help, many times they're misdiagnosed because of a lack of cultural awareness and appropriate treatment. And we also see that many times people from the Latino populations don't go back to services because of the experiences they had with their provider, with their teacher, with a school personnel, principal, administrator, whoever that may be, that may not be thinking about some of these cultural aspects that we're thinking about. So now in school settings, I mean, look at our time real quickly, folks. All right, I think we're doing good. I think it's your time 1:30, getting close to 1:30. So we have about 30, 40 minutes left. So now we're going to start to kind of pare this down a little bit and drill in a little bit deeper, if you will. 2 points that I think are extremely important to understand is that teachers and school staff in particular, but many times teachers have a more intimate relationship in the sense of a professional relationship, and really know their students pretty well. I know that given public schools, sometimes that's hard given the 25, 30, 35 folks in one classroom, but a lot of times teachers and school staff even are that important conduit for promoting connectedness, right? You all are promoting whether individuals feel connected to school or they don't, whether they feel connected in your classroom or they don't, right? So first line detectors of suicidal behavior oftentimes becomes teachers, counselors, school social workers, potentially school psychologists, obviously. And then we also see, even in some settings, cafeteria workers and janitors or other school staff, EAs, educational assistants, people that you wouldn't think would have a relationship directly with young people and the students. You'd be surprised how sometimes those folks are really connected to young people. So you're going to hear me in a little bit really promote the fact that we need to train all of our school personnel, not just our teachers and our school social workers and our counselors, but we have to train our janitors and our custodians, our cafeteria workers, right? The ladies are cooks that provide service and nutrition to our youth. We have to include them in that training so that they're a part of it. So looking at this section is coming to you from our school-based mental health curriculum that comes out of the National Center, Mental Health Technology Transfer Centers as a collective, and really starts to pare down now what can we look at specifically within schools in order to promote more positive outcomes. So school mental health promotion model really focuses on the importance of universal social development, character building, and social emotional skills, right? SES. That really is an important aspect. As we know, many schools are now looking at social emotional support elements within their schools, right? Not so much solely through a educational lens like we have for so many years. And I would say that I'm hopeful that more public schools are embracing this. However, I know that public schools are typically behind a little bit within the adoption of new models and approaches. So many of our charter schools, or those that are kind of not directly affiliated with public schools, may be more progressive in this area of social emotional learning. We also know that this model equips staff and educators to implement classroom-based lessons that impact positive behavior, social inclusion, and effective problem-solving skills. And those skills not only include giving people different ideas on how to cope, right? Like exercise, nutrition, talking with someone that can relate to them, peer, connectedness. But it's also really helping to draw those experiences down within the institutions as well. So we can't just talk and preach about this, but we have to really replicate and create these opportunities for young people to be involved in that. And we definitely see through the research, which we didn't cite any of that research there, but it's plentiful, where we look at the positive outcomes, an increase in academic performance when we're considering social emotional learning in schools. So the center can provide these 3 different levels of technical assistance in your agency or your school if you seek that. And we hope that you reach out. Either reach out to me at the email address I provided, send us an email to the email address I'll provide here at the end of the presentation, and we will assess, what your need is, and based on your feedback, and decide, do we need a more universal approach, all school population around suicide prevention? And in my mind, that's exactly what schools need. Sometimes rural communities and rural schools are less maybe ready or prepared or equipped, or unwilling to talk about suicide in their schools. Administrators and principals sometimes, even when we look at some of the leaders within the larger kind of system of education, We see them sometimes not willing to engage with suicidal talk and prevention and education because they think that it's going to encourage young people to think about suicide, or it's going to bring it to their mind. Well, I will tell you what, folks, if we're not doing it as schools and really producing some positive understanding and not providing accurate information that is data focused and is accurate, they're going to get misinformation from their peers, from other communities, maybe even from parents. So we have to provide that. So these 3 tiers, you can ask for universal, all school population, more of a targeted, is it classroom intervention or a subgroup, maybe teachers, schools counselors, school social workers, or is it an intensive? Is it with a specific population that may have suicidal behaviors already, where you're seeing examples of suicidal behavior showing up in your school, like somebody doing self-harm, cutting themselves, burning themselves with erasers, maybe even overdoses. You're seeing an increase in overdoses within your schools. Those all may be signs or symptoms that lead to suicidal ideation as we see it. Now, I think it's really important that you understand each one of these is a different level of implicit and explicit training and involvement, from not only policy development at the intensive stage, but to some very basic education, and maybe having some elements of community forums at the universal level, at the beginning level, right? Where you have not only community forums, because one thing that you always have to do, I believe, is if you're training if you're training students in your school on suicide prevention, awareness, mental health, first aid, you also have to train their parents and their loved ones, right? It does us no good if we don't have the support at home in the community when they're away from school. And don't get me wrong, I understand how much time they have in school, but when they're out of school at 3 o'clock or in the weekend or in the summer or spring break, we want them to still be able to have support at home, and family and friends and other community members that can recognize suicide behaviors and intervene as appropriate. So there may be this multi-leveled tiered approach, and you may be asking for 2 of these different tiers, or maybe all 3, right? So just think about that a little bit. I think the other thing that I want to mention on this, and I didn't include it, I should, and I probably will as we finalize some edits within this presentation, but I think it's important to know that there's a teen and an adolescent and young adult, children and young adult, and even again adolescent, more specifically the young adult model that is called the Yellow Ribbon Campaign, and that is out of Colorado. And actually a wife and her husband created this model after their, I believe, 17-year-old son at that time took his life by suicide. And it's been a model that they've continued to promote, and they're trying to create this evidence behind it. But I will tell you, it is really a full, comprehensive, community-based school intervention model that includes not only meeting with school personnel, doing all these different levels of training, but also with students, families, and stakeholders in the community. So if you're really wanting a comprehensive look at suicide prevention, definitely take a look at that as well. This summary slide is just a way for us to, again, summarize the previous ones of saying we want to definitely focus on intervening in schools that especially have high risk behaviors, and those are more where we're intervening, providing treatment. But then we have to also take a step back and look at prevention, right? What are we doing to prevent future suicides? So again, the second statement here really mentions the time, right, that students have in school. So we really want to make sure that we look at all aspects of resources, transportation, also basic Maslow's hierarchy of needs. We look at food and nutrition. All those factors should go into our formulation interview as we're creating our diagnosis and done at intake. The role of educators and professionals. I think the overall goal, as we're starting to create an awareness within your school at the general level, should be increasing cultural awareness. Advocate for more culturally appropriate assessment and tools like we're doing here, Cultural formulation interview is one of those, and then of course some of the other models that we recommended. Increase with engagement with Hispanic and Latino students and families is critical. Families is critical. And I always say this, and I don't mean any disrespect, but we don't do cultural nights at the school like let's have a Mexican night, let's have a South American night, and we'll have foods from all these different countries. That's great. That's all good, but that has to be paired with some sort of valuable education and resource, right? We're not promoting and we're not doing parades of culture. We're not here to tokenize Latinos or Mexicans or any other racial group or ethnic group. But this should be explicit and implicit, integrated within your policies, within the framework of what your school or your community-based agency does, right? We shouldn't just say, oh, once a month it's Hispanic, or once a year it's a month of Hispanic Heritage Month. Let's go ahead and have taco night, or those sort of things. No, that in many times does more disrespect than anything. Now, I'm not saying that we shouldn't have tacos or we shouldn't have good food, and food isn't a part of our culture. It absolutely is. But that shouldn't be the highlight of someone's cultural values or their cultural experience. That should add the flavors to that, right? But we should have other aspects of that, like familia, like respeto, like being a part of the community and inviting families in to be a part of the school system, whatever that looks like for you. And then number 4, connect culturally relevant mental health services. That's a huge part of this, right, that we're trying to promote. Let's see where we are, 11:36. Okay, I think we're good. School administrators, I think it's our responsibility to design and promote school-wide campaigns that support diversity and inclusion, create and support opportunities to increase cultural awareness through professional training and staff development. And that includes specifically what we're talking about here today: suicide prevention, intervention, and treatment. Foster a community of partnerships, not only with both formal and informal community links, parents, community agencies, community groups. We definitely have to see and be aware of blended status immigrant families, meaning that some members of the family may be here legally, or maybe again born in this country, and others may be here through different means, whether that is legally or illegally. And we have to just understand that. And I firmly believe that schools should not be a place where families are arrested and ICE is called. Families, I think, should feel safe in their home, in their school, and schools should find areas of empathy, I guess I should say, and protect those students, protect those individuals, especially those individuals that are coming to your school and bringing some knowledge and experience and some different cultural aspects that maybe your school has never experienced before. Advocate for school policy. That's definitely school administrators' role. That is multilingual information providing. I think, again, I don't know that we reference it here, but class standards, cultural linguistic standards that mandate from a federal perspective. If you receive federal dollars as a school or community-based agency, you are required to provide information, training, education, and services in the language and with cultural considerations of the population you are serving. So that means that it's our responsibility federally. Now, are there class standard police out there? Not necessarily, but you never want to end up in a lawsuit or some sort of situation where there's complaints or claims of discrimination or racism because you are not considering cultural awareness and sensitivity training for your staff. So it really makes it important to do that annually during your professional development. We have done that a number of times around the country. So any of you that are attached to schools that have some, staff training, and you have your in-service time, before school starts, a month, 2 weeks, whatever it is that you go back, consider reaching out to us and integrating some of these trainings in your trainings for your teachers as they get back for the new school year. Mental health providers, I think that here it's our job to increase cultural awareness, definitely foster community partnerships. We definitely want to make sure that we're paying attention to acculturation stress migration trauma and discrimination, and that you definitely receive appropriate training to integrate use of the CFI in clinical care. We're hopeful that you are able to do that as we move forward. And then I'm sorry for this formatting issue here at the bottom. So we definitely want to encourage you to learn about culturally responsive school environments for mental health, some of that which we're providing to you all today. And then educators and paraprofessionals, seek out that cultural awareness training. Be trained in mental health first aid as a general curriculum, but hopefully we're able to get this curriculum out to you all in different parts of the country, and you can utilize some of this work that we're providing to you that Dr. Zayas and Dr. Polanco have contributed to. I've been very fortunate to be able to create the PowerPoints that we're using for this training, and adding some of my experience in not only being a survivor of suicide, but have studied suicide for a long time now, the last several years. Lastly, we want to make sure that we're recognizing immigration trauma and migration trauma, right? Like I said, this is kind of where we kind of start to really look at organizing our efforts. Think about creating a mental health task force in your school. Many times that may be the school social workers or counselors, but I would encourage you to create a mental health task force that is very diverse, meaning that you have one social worker, one school or a school counselor. Maybe you even have a cook from the kitchen or from the cafeteria, an administrator. Maybe even have one of the teachers or a coach or someone that gives a view of all students, and including on that mental health task force, you also have a student representative or a couple of student representatives, especially considering the other aspects of culture that we don't think about, like aspects of LGBTQ that sometimes are interfaced, or there's this intersections of culture, ethnicity, race, and LGBTQ issues that are going on in our schools and communities as well. Custodians and food service workers, I can't stress this enough. I think too often they're left out of trainings, right? And I know it's because we maybe don't get paid, or their time is more valuable to be in the kitchen, or whatever the reason, we exclude these individuals. And many times they are connected to kids and more engaged with kids than we may be as school staff or as school teachers or social workers, etc. And the most important thing, and one of the cool things that I like about the Yellow Ribbon campaign, is that they teach you, or they advocate for you as school administrators and staff to train everybody in the school. And they even give you these yellow ribbon cards. And I don't think I have one handy here, but it's a yellow ribbon card that basically says, and we train students and the staff that we train to be able to recognize when a student is in crisis, and that individual can give that yellow ribbon card to a school cafeteria worker. And basically on the card it says, basically, I'm overwhelmed with stress and I need help. I have thoughts of suicide, and something very general of that nature. Please help me in that sense. And the training really means that if someone gives you that card as a adult or a school personnel person or staff member, that they trust you, first of all, that they feel connected and they feel that you've respected them. And secondly, that you, as the person that's receiving that card as a school worker, you're not going to leave that person's side, that young person. You're going to take them over to the nurse's office or the school social worker or counselor, and you're going to sit with them and do that warm handoff until they are connected with help, with the lifeline, right? We definitely encourage some very basic training in the referral process for all school personnel, including custodians, food service workers, and then again, maybe a general training of mental health first aid as well as suicide intervention, but really connecting and communicating that with families in order to promote our communication and integration fully. I think that we have to, just as a reminder, use language as a part of the transformative experience, right? We could very easily continue to use language that shames individuals, that they have because they have suicidal ideations, maybe even a plan, maybe they've even had attempts. Or we can promote wellness in our schools and our communities by saying we are here to help and support you. This is what we're doing. We're doing training. We're giving you information. We're giving you access to get support in a culturally appropriate and sensitive manner. And we're hopeful that using person-centered language can serve as also a mechanism of a change agent, or those of you that are agents of change, right? Increased awareness and self-reflection definitely are needed for those of us that work with Latino youth directly, and really knowing that our importance of our role is just that, extremely important. So in summary for this school-based slides, I definitely, again, train school staff on implicit bias and other types of culturally competence, to include our training on suicide prevention, create an atmosphere where teachers can identify, discuss, and find solutions for instances of bias, because we know that bias, and I want to highlight the youth risk and resiliency study and data that is out there. If your school participated in it, or your state, I would highly encourage you to take a look at the data sets that they provide a summary of. Many of those have implicated schools as being sites of creating a sense of not being safe to young people in their school. And I'm referencing my school, so don't take this for your school is saying this, but in New Mexico, this is what our students are saying of their schools, is that they may not feel safe at school, that they don't feel that they're connected to the school in a healthy way, that they don't know where to get help or seek help, that in general they're feeling a general sense of apathy and hopelessness for their future. And this is more specifically with Latino populations, right? When we look at that compared to the national average of their white counterpart, they're extremely higher numbers than white students. So what is our recommendation? Train, evaluate, retrain, and assess your outcomes. Use data to drive your decisions. If you see Latinos, because we really have to ask ourselves, because I know tons of individuals that come from Latino populations, all different parts of the world, right? And many of them are extremely bright individuals. On the counter side of that, many of those individuals dropped out of high school early, maybe went on for their GED or otherwise, or then went on for college degrees and are extremely successful. So we shouldn't always measure that data that is saying Latinos are dropping out of school early, which is extremely true and at very high rates compared to the national average. What is the system or that school doing to increase the number of Latinos dropping out of school, right? We can't always blame the victim. We have to sometimes turn that critical reflective eye on us as the system, or us as the professional as part of that system. And I know sometimes that's a hard pill to swallow, right? We don't want to call our baby ugly, our school, our agency, our project, but if it's producing data that is not showing successful outcomes for Latino students, like completing graduation, less visits to the nurse's office, less truancy or absences, increase access to counselors and school psychologists, right, by the number of referrals that they see. There's ways to track that information to really make your decisions of a more focused mental health task force that can help you down the road. The CFI has a tool in school settings, and I want to thank the folks that adapted this material, Daris, and I know she has experts, content experts, including Dr. Zeas and Dr. Palancas that has worked on this. So what we've done is amended and kind of giving you some thoughts and ideas on how to look at the DSM-5 cultural formulation interview. We sent that to you last week as an attachment. Those of you that were not with us, you can also here on one of these slides, when you get these slides, look at the link that's there and follow that link, and you'll be able to also get that cultural formulation interview as a document PDF. All right, so what is the cultural formulation interview? Well, it's a tool that was an instrument that was identified and developed and is a part of the DSM-5 now. It's part of the appendices in the back if you look that up. And it's used as a cultural formulation to supplement the diagnostic assessment portion of the DSM. And we're hopeful that you get a sense that it does is provide an opportunity to assess those variables that will affect cultural issues in treatment, right? So one, cultural identity of the individual, cultural conceptualization of distress. That may be a little bit difficult with our teens and young people, but I think if you start to think through those questions, you can come up with ones that really will help you get to those conceptualizations. What are the psychosocial stressors and cultural features of vulnerability and resilience? Immigration stress, the immigration journey, right? Minority stress in general, when we look at racism and discrimination. And then cultural features of the relationship between the individual and the provider are definitely important at this assessment phase. And then again, the overall cultural assessment, we hope that you'll utilize that in conjunction with the diagnostic part of things. Because in some cases, the issues that may be presenting to you may be no more than issues with adjustment that this person is going through. It may not be full-blown, depression or post-traumatic stress disorder, but it may be those things as well, right? So we have to utilize both instruments and tools in order to be most effective and to create the best clinical picture that we can for outcomes. So just in summary, it's a set of 16 questions that really looks at impacting or assessing the impact of culture as key aspects for the individual's experience. There's 4 domains. Questions 1 through 3 look at the cultural definitions of the problem. Questions 4 through 10 look at cultural perceptions of cause, context, and support. So those are the things that we look at, like mal del ojo or ataque de nervios, right? Attack of the nerves, or the evil eye, the bad eye that some Hispanic and Latinos experience as part of their mental health symptomatology. Questions 11 through 13 look at what are the factors that have increased self-coping and have helped in the past through help seeking or otherwise. And then the last 3 questions, 14, 15, and 16, look very specifically at cultural factors affecting current help-seeking behaviors. The informant version of this really gives just another view of just getting it from the informant, getting it from the individual. So really taking what they have to say, doing a lot of quoting and citing. So it definitely is coming from, I guess, what I would say a qualitative kind of approach, right? It does follow the same format as the primary cultural formulation interview. The Hispanic and Latino individuals frequently desire to bring family members into the assessment process, so that can also help, right, as them being informants of what's going on with the situation, which will help you kind of create your picture during your intake and assessment. And then again, this informant version may be ideal in these situations again, so it's creating a more clinical or clear clinical picture. More specific to school-age kiddos and adolescents, for the CFI supplementary module, we want to it provides you with specific questions to assess culture and youth's and mental health conditions. It amplifies the information, again, by asking the collateral and again, even informant information and perspectives. And then the questions definitely could be asked by interpreters. I think, though, that if you do it through an interpreter as a clinician that doesn't speak the language of the person that you're serving, these are some factors that you want to consider. The child's age. Is there intergenerational difference between the child and his or her network or family or parents or grandparents raising grandchildren, as we see a lot in our communities and schools? The degree of the emotional symptoms that are present, does this create a need for a higher level of care for us to consider maybe more intensive, maybe intensive outpatient, maybe we look at an inpatient even just for that intake and to do a thorough assessment. And then, of course, we always have to think about adverse childhood experiences, like I mentioned last week. And I think those are going to be key in kind of creating this complete picture of what our young people are going through as they experience mental health and suicidal ideation in some cases. So let me take some questions here. Susana Frias, what does SI stand for? Suicidal ideation. I'm sorry. Yeah, suicidal ideation is the abbreviation for SI. And then I have a comment here by Rigoberto. I work with teens and young adults. Language is also a big factor in regards to how the information is given to parents and the teen. If the clinician is not Spanish speaking, they at times do not express the concern, danger, importance. The concern is lost in translation. I couldn't agree more. And if you all don't speak the language or don't have someone there in your school that can serve as an interpreter, and I'm not talking about going and getting the cafeteria worker or the custodian to come in and to interpret your session for you. That is not ethical, and that is not how we should do things. Now, in an extreme case of an emergency where someone's life is at risk, maybe we consider that, especially when we're looking at kind of rural practice and rural medicine, right? But that should never be our number one option. There's plenty of HMOs and these insurance carriers now also that can provide you access and connection to an interpreter as well for services that may be seen. So thank you, Rigoberto. I couldn't stress that enough. That's extremely important. I think that many times when a Spanish-speaking family comes in and they have a non-Spanish-speaking provider, that many times they don't express the intensity, they don't express the trauma and some of the true behaviors that are experienced within a family at that time. And I hope, Rigoberto, you can probably I guess, affirm what we're saying is the more that you have a relationship and you've treated this family with respect and integrity, the more apt that they are to build that relationship with you and be willing to share those family things that are going on with you, that usually that is very guarded in many ways, right? So thank you, Rigoberto. I appreciate you saying that. Fausto, any comments about mixed Anglo-Hispanic families and how to manage this? I would always just ask what the family is basically following in terms of their cultural values, their family values. Do they tend to believe more within kind of the Latino population belief systems, things that we've talked about here? Do they talk more on more of an Anglo kind of approach that they've acculturated and now are more affluent or acculturated or assimilated even, if you will? So I think it's really assessing the level of acculturation. If somebody is fully acculturated and they feel like they're more a United States citizen and don't really practice some of their traditions or their beliefs, I would then stay more on that side of things, right? However, if you're getting a sense that there may be a blended approach to this where maybe they're trying to adopt values and rules of American society, yet some of their belief systems, like around grief and loss specifically, is still bound by cultural belief systems and traditions, you may then have to, and religion and spirituality become a tremendous force in this decision making. You definitely want to consider that and have that conversation with them. So I appreciate that question. That's a really good question. Thank you, Fausto, for asking that one as well. And then the last question, then we'll get back to our presentation here, is do you have any thoughts about the literature which suggests that Puerto Ricans are at higher risk of suicide than other Latinx ethnicities? I really think that what we have to consider is those cultural crises that maybe folks are experiencing, right? When we look at biculturalism and ambiculturalism, sometimes there's a tremendous amount of stress put on those of us that feel like we're split between cultures. Mainstream culture, our traditional culture, maybe in this case, as Mindy is asking, thank you for the question, Mindy, that maybe somebody is split between their very traditional Puerto Rican culture and valuing that and holding on to that, and the fact that Puerto Rico is a territory of the US kind of thing, right? And I know that sometimes those factors can also contribute to identity crisis and identity issues. So I would really try to really look at that more specifically with the population. What I would very much ask you to do, Mindy, because I am not by any means an expert, although I consider the folks out at the center, the mental health technology transfer center, to be family. As a team, we worked together for many years. I'm not myself Puerto Rican, but I would encourage you, if you want to reach out to me. I know that there are some clinicians on our team that would be more than willing to talk with you more in depth about this and really get down to those specific kind of interventions and maybe treatment approaches that you may want to consider in your work with Puerto Ricanos. So thank you for that. I appreciate that question. So now let's jump back. We're getting pretty close to the end of our time together. And I just want to reiterate this, folks. You know, this content that we're talking about here, sometimes this content, again, can be presented over a whole semester, over a 2-day period. You know, we're trying to bring you an hour, roughly hour and 15 minutes each week. So we probably could have had maybe 2 more module or 2 more sessions with you all. But I want you just to make sure that you reach out to us. You have us as a support. I know for myself in my community, early on as I started to do this work, it was always like I was working in a silo. Not a lot of people were doing suicide prevention. Not a lot of people were comfortable with doing prevention, intervention, and treatment even. And many people were kind of thrown into this, right? So we've done over the last 10 years in New Mexico a lot of work of training school personnel and folks that want to learn about this work and really bring that awareness to their school setting. So I ask you to reach out if you need that. Some of the supplementary questions here, just to follow up, that focus on you know, the CFI, and this is a supplementary module again that we're talking about, cultural formulation interview, is that questions 1 through 7 usually focus on feelings of age appropriate in different settings, home, school, and church. 8 to 10 are more age-related stressors and supports. Questions 11 through 14 are age-related expectations, i.e. chores, discipline, rules, getting home on time, what's their curfew, all those kind of things. And then questions 15 through 20, the transition to adulthood and maturity, and that one is again specific for adolescents, and I would even say young adults. And again, handbook on cultural formulation interview, we've shared that with you. It's one of the links here, so you should have that as you get this presentation as well. So looking at this kind of application, we definitely want to make sure that it adds and you consider the collateral. So what is involved in that kind of echo map of that individual, what's going on in their environment, what other systems are they involved in. Adapt the questions to be very specific to your population, especially if you are in a school setting or a community-based organization that may be different. Be very brief and specific, right? We don't want to, if we're looking at dealing with suicide prevention in our schools, we don't want to really spend all this time. I think what we want to do is do it regularly, get in, train folks, get out, but have things in place like a mental health task force, like a very specific referral process, because it's imperative that if someone reports suicidal ideation in our school, that at that moment protocols fall into place and you start to follow those protocols very, very specifically, not only because of liability, but obviously safety and wanting to preserve that young person's life at whatever cost. And if we have a very specific approach that is consistent, you can then really look at that. I would also look at the Columbia scale that I shared with you all. Again, remembering that you may have to adapt and really look at that. I do know that, and I haven't brought that up lately, so I can try to find that if someone reaches out, but there is a very specific intake and assessment that is suicide specific for adolescents and teens as well, that we want to make sure that you think about. And be creative. I can't stress this enough. The more that you can make young people smile and have some hope and have some connectedness with you as an adult, maybe as an adult that is different from the experiences they've had with other adults. You know, I had a student, and I'll share this with you, who probably had it, and she was a young, probably at that age, she was 16 going on to 17, had shown up. You know, I had seen her a few times before. Really very flat affect, never really any emotion other than sadness or flat affect. And we at this time had adopted at our agency that I was started and working at that time, we had adopted a rescue dog, and we brought in a pet therapy dog as an emotional support dog. And I can't tell you how that young lady's face just changed, her perception, her willingness to want to see the dog the next week, and really kind of connecting with that animal. So pet therapy can be extremely important, but be creative. Let's get outside of what we've done traditionally, maybe that hasn't worked for us before, and really be creative in how we do some of our suicide prevention campaigns and maybe public service announcements to our students in schools as well. I'm going to read a little bit of this case study. This is going to be more for you all to utilize as you go back to your schools and you go into, you're hopefully creating a mental health task force. I would love to hear from you, any of you, those that go back and really look at this. And I just ask you to kind of think through some of these questions and relate them to what's going on in your community or clients maybe that you're seeing. So this specific young lady is Lorena. She's a student from Guatemala City. When she was 8 years old, her family relocated to a small rural town in Guatemala to escape gang violence, only to confront it again in their own new town. When Lorena was in middle school, a neighbor who was a gang member began to express interest in her. When she refused to become his girlfriend, he began stalking and threatening her. During her walk home from school one day, the same gang member and his friend took 14-year-old Lorena by force to an isolated area and raped her. Lorena changed schools to avoid the gang member, but he continued to follow her and repeatedly threatened to rape her again. She eventually fled to the U.S. to escape further sexual violence. Lorena presents anxiety about going to school, does not speak or understand English, seems depressed, and presents making difficulties and present difficulties making new friends and adjusting to her new school. Some of the questions that we would ask you, right, to think about, and this is again based on how the cultural formulation interview may be used. So what would you like to know about the client that you did not know already, right? So what is there, 3 or 4 bullets there? You definitely want to think through some of the other things that we haven't mentioned in that short piece of things, but think about what we've talked about already, right? What are the important cornerstones of cultural value systems and what this young person may need? So initially, what we want to think about is really looking at what do they have or who is in their immediate support system. Do they have parents? Do they have siblings? Do they have others in that family system? Another huge issue that we have to consider is safety. Is she safe currently? And maybe, again, safety from her previous predator and stalker that was perpetuating violence and emotional and psychological stress and trauma on her. We want to know that she's safe, right? Safety is paramount. We also want to start to get to know if there has been any, as bullet number 2 starts to talk about, has there been any current treatment that she's attended? Maybe that is spiritually, maybe she's gone to speak to somebody in her church community, maybe she has gone to a school counselor and had a bad experience, maybe she's gone to a doctor who maybe was very invasive, culturally insensitive, misdiagnosing what she was trying to present and what she was trying to report. If there was a rape that was happened as she reported, was there a rape kit that was conducted, and was there any of that collateral information that we need to think about, right, in terms of our assessment? And then we also want to look at number 3, if she was a student in your school or even in your community-based organization serving students, what are the cultural factors that you would need to be considered based on living in a new country and trying to socialize in a new school environment? That developmentally, you definitely want to know, have there been any breaks in the normal developmental stages? Has she met her developmental milestones, efficiently and normally, whatever that looks like for this specific young person? We also, for immediate need, we want to make sure that we know, what was her journey and acculturation and immigration experience. And as you saw from those 2 or 3, the 3 or 4 bullets we have, it was very violent and traumatic for her, right? So even if we just look and do a quick kind of overview of those 4 bullets, and let me go back real quick here, right? Even if we were to just do a scan of these, we could very much pick out, especially if you're knowledgeable or if you've gotten trained in adverse childhood experiences or ACEs, you could very much pick out almost 3 adverse childhood experiences right off the bat that is going to contribute to her decision making and to her experience, right? So not only acculturation, identify those generational gaps, but we're also looking at what are the adverse childhood experience that this young lady may have experienced along that immigration journey. Not only personally, but did she witness her family, her mom, her dad, her siblings, aunt, uncle, anybody else getting treated violently and getting, attacked or, heaven forbid, raped as she did, right? So all these different factors come into play. Of course, alongside of that, what you're trying to draw out is, has this led to suicidal ideation, suicidal planning, any attempts, any self-harm behaviors that are going on that we really want to understand? And then again, how might you use the cultural formulation interview and the informant version in Lorena's assessment? You definitely want to go through that thoroughly, pairing that up possibly with a suicide risk assessment. But you also want to start to get input from the informant version from those individuals that are a part of her experience, family, friends, peers, if that's the case, loved ones. And again, I say loved ones, that may be mom and dad, that may be grandparents, right? But in some cases, we've seen young people immigrate to this country, and even in extreme cases, still being held hostage and kidnapped by their coyote human traffickers, right? For ransom or for doing specific jobs that they have for them. So we always have to understand what that specifically looks like, and if any of the family experience as a family unit have had those experiences, it's potentially going to lead to this vicarious or secondary trauma, again, through oral history that we see many Latinos carrying on as a cultural value. Some additional reminders. And this, again, I think is just in summary. I know that case study is very brief. I would encourage you to go through it. You can even, again, reach out. I think we have other case studies that we could probably share with you. We're going to embed other case studies within this training as well to make it more interactive when we do this training live. So I'm hopeful that some of you reach out to us if you have that interest and are willing to become a trainer. We will promote and send out save the date notices. So I'm hopeful you signed up for our newsletter and our announcements that you will get. So some factors to facilitate really having a good approach to suicide prevention. A suicide prevention program includes well-defined crisis policies and procedures, communication of these procedures, collaboration across staff, and the presence of on-campus mental health resources. A mental health task force is extremely important. If you have a school-based mental health center, if you have a nurse's office, that they house a counselor or a school social worker, you want to promote that. You want to promote that through wellness, and also through opportunities of teachers making referrals and other school staff making those referrals as well. I want to encourage you guys, if you have any other questions, please put them in the comments now. Sometimes those take a little while to get to us, so I want to make sure I spend the last 10 minutes or so answering those questions and making sure we send you off in good fashion here. We definitely want to make sure that we emphasize direct teacher training on risk factors for suicide, crisis response, and classroom management. That is extremely important, because we know that sometimes in schools we have copycats, right? Individuals, or in one school that I was a intern at, believe it or not, thank God I was trained and I had a way of reporting that, and through my faculty at the university, I was trained to always include your supervisor. I uncovered a student who was self-harming, and it ended up being that there was about 4 or 5 other students, her peers, that were also self-harming, and it was all based on a suicide that happened the year before in their junior high school that was never addressed. It was never taken seriously by the school staff. And now those behaviors trickled over the summer and into their freshman year at high school. And if it wouldn't have been for me kind of seeing someone's marks on their arm and asking more about that, and then reporting it, and us creating a whole mobilization kind of effort around those students, we may have had more students take their life by suicide. So we have to be responsive and we have to be participatory. We can't just allow someone to present, or you find a letter, or someone makes a comment like, I should just die already, or I don't want to be here anymore. Those sort of comments need to be taken seriously. And we need to pull that student in. We need to ask them questions. We need to have a family visit and really talk about those things. And we're hopeful that by arming you with this information that you feel more confident in having those conversations. By bringing it up, I want to reassure you, it's not going to make somebody go out the next day and take their life by suicide. If anything, it may have saved their life, and you may have preserved their life. And continuing to be a warm response to them with empathy, chances are they're gonna stay in that. And then lastly, in-school trainings on mental health resources and procedures is extremely important. This, in my mind, should happen at least once a month or at least once a quarter within the two halves of the school year, the fall and the spring, and have these in-service trainings regularly. And then lastly, we want to present you with some resources here. Preventing suicide, the role of high school mental health providers. There's some links, the DSM-5 cultural formulation interview, the CFI informant version, and then the supplementary modules that will help you within the schools. And then we also included SAMHSA's toolkit for preventing suicide, a toolkit for high schools. The other one that I wanted to mention is the Yellow Ribbon campaign is really good. QPR is good. That one is more specific for adult populations. But I think that, again, if you have interest in adolescent or high school or even mid-high settings, please reach out to us and we can help you to locate those resources as well as you move forward in this. I think we already said this, and then we had some last slide here that I want to mention is just be aware of vicarious trauma, right? As providers, as individuals that talk with kiddos and young people and families about suicide, about grief and loss, about death, we have to understand that sometimes that trauma attaches itself to us, right? And we have to seek out our own support, seek it out through your own private counselor, your own education or employee EPA, your employee assistance program, or EAP, I should say. And then again, if there's issues that you have through transference, countertransference that's going on, I think it's important for you also think about your unresolved grief and loss that you may be experiencing, right? Think about that and how that's impacting you and how it's impacting maybe your decision making, maybe your willingness to engage with clients, students, families who are presenting suicidal or ideation or intent or a plan. Instead of shying away from that because you may have your own reservations of your own grief and loss, we can start to engage that and really make sure we can address it fully. All right, so I'm going to go to questions, and while I'm doing questions and answers, I have one question here. So I want to make sure I get to that one, and if anybody has anything else, I'll ask if we have anything on our moderator side as well, and if not, then we will be good to go. I want to please ask you, and I can't stress this enough, to please scan this link or go to the link here at the bottom, surveymonkey.com/r/62YY6QT. Fill out our GIPRA form. It takes a few minutes. It asks for some unique identifiers, but it's not tracking any of your social or any of that private information. But what it does track is these sort of trainings that you attend throughout your career, and it can also help with us knowing what you want in terms of trainings down the road. So please take the time to answer that, and it really helps us to get continued funding to provide these trainings for you at low or in many cases zero cost to you. So we ask that you do that. Well, before I get to the last questions, I want to thank our director, Dr. Ives Carrion, who's the director of the Mental Health Technology and Technology Transfer Center, also the director of IDISA, Institute of Research, Education and Services and Addiction, through the Universidad Centro de Caribe. Also our project manager, Angel Casillas, thank you for your support. Again, we want to make sure that we connect with you. So if you have questions on any of the things going on in your school or presentations that you need, technical assistance that you need, please reach out. And thank you, Rigoberto. I think that with some of these social media sites, and Rigoberto mentioned suicide pacts are becoming common in schools, right? So copycat or pacts that students are making with each other. That's exactly the experience I had several years ago. But I know now with even with social media and TikTok and some of these apps, you know, young people are making these pacts to do things that are outside of what we've normally seen within schools and within communities. So we have to be that much more trained and heightened and really think about those things moving forward. So I want to make sure, let me just look through these questions again. I think I got to all of them. Yes, I did. Awesome. Awesome, awesome. Thank you so much. So I'm going to go ahead and stop sharing my screen here real quick so that I can see, or you can at least see my face one more time. Do we have anything else going on there, Miss Cindy, on our side?
No, we don't have anything. You cover all the questions.
Awesome.
There's a clickable link for the evaluation on the chat. If anybody can do it now or later, they can copy paste it somewhere. But thank you again, Dr. Romero, for an excellent presentation and all that information, very crucial. Thank you all for being here. Hope every one of you have a great day. And you can always reach out to us for in our emails.
Yes. Thank you again, Cindy. I appreciate it. Thank you, everybody at the center, whole team, and thank you all to those of you out there doing the frontline work and intervening with our students and families. Please reach out. We want to support you. You're not out there alone. Thanks again. See you later.